And with that, it's my pleasure to turn this over to our featured speaker today, Dr. Cindy Ellis. Dr. Ellis is a professor of pediatrics and psychiatry at UNMC, as well as the director of developmental medicine at the Munroe-Meyer Institute for Genetics and Rehabilitation. Thank you.
Hi, as Laura said, my name is Cindy Ellis, and I'm a developmental pediatrician at Munroe-Meyer Institute and Children's Hospital here in Omaha. And one of the primary things that we do is see and manage autism. So today I'm going to talk about some of the core symptoms of autism, screening and early identification, diagnosis, a little bit about treatment. This is a very important issue in pediatric behavioral health, and we know that autism affects more than 5 million children and adults in America, and the cost of caring for this population is estimated at over $250 billion a year. The lifetime cost for one child, which would include healthcare, education, other costs, ranges from about $1.5 to $2.5 million for the lifetime cost. That's a lot to raise a child, and depending on their comorbid conditions. It's really important for developmental pediatricians, primary care providers, because primary care providers are critical to ensuring that children get lifetime care if they have autism spectrum disorder. Pediatricians have access to children through the medical home, so they can see signs, screen, and early identify. They can support families through the process of diagnosis interventions. They can understand the etiologies and help parents understand options for effective treatments and decision-making, and they can help co-manage medical issues. American Academy of Pediatrics published their most recent guidance on autism management in 2020. And this was updated from, I'm sorry, my slides keep going automatically, updated from recommendations about 12 years ago. Since that time, we've seen an increase in the prevalence of autism. There is an expanded awareness of coexisting medical conditions. We have improved genetic testing. We have increased evidence base for interventions, and we have the DSM-5. So much of my presentation today is coming from this standard practice clinical report, these guidelines for identification, evaluation, management of children with autism. And you can get this online. First of all, I wanted to talk about the prevalence, and the newest data is from 2018, shows that there's 1 in 59 children age 8 years old with autism. This is an increased prevalence from 2016, where it was 1 in 68, but the data now shows that this prevalence seems to be stabilizing. The US rates are similar to other industrialized countries. You'll see some lower rates reported in resource-limited countries, but that's generally because epidemiological data are unavailable. We see that autism is diagnosed in more males than females, and there's a higher prevalence in white non-Hispanic children compared to Hispanic and non-Hispanic Black children. If you look at the CDC data from 2014, white non-Hispanic children are 20% more likely to be identified with ASD than non-Hispanic African American children. And they're 50% more likely to be identified with ASD than Hispanic children. The most recent prevalence data also indicates increasing rates of ASD in Hispanic and African American children, so that this is really important for us to remember. And we know that earlier diagnosis is associated with higher socioeconomic status and access to services, meaning that the kids who have a lower SES and less access to services don't have that early diagnosis. Is there an autism epidemic? And I think that's one of the questions that parents ask us most often. And the answer is that there is an increase in prevalence over time. That is true. We have seen that. Some of that relates to the changing in diagnostic criteria related to the DSM. This is particularly relevant for the DSM-4 in the mid-90s, which broadened the diagnostic criteria for pervasive developmental disorder. So it was kind of classic, children with classic autism, and that was expanded, which increased the prevalence. There are also a number of children with autism who were previously diagnosed with an intellectual disability or a speech language impairment or another developmental disability. And with the increasing awareness and testing in schools and in medical settings, many of those children are now more appropriately diagnosed. That's called diagnostic substitution. There's also been increased public awareness, and recommendations for universal screening have identified more children. But we also know that there's probably a true rate increase associated with other biological factors. There are a large number of clinical symptoms and behaviors associated with autism. It's a very heterogeneous disorder, and it's very difficult to I'm sorry, my slides keep advancing. It's very difficult to put them into single boxes. We know that children with autism manifest the behavioral characteristics that present differently depending on their age, their language level, their cognitive abilities, and atypical development in several functional levels contribute to the symptoms of autism spectrum disorder. So there's a common saying that you've seen one child with autism spectrum disorder, you've seen one child with autism spectrum disorder. In preschool children, language delay is typically the presenting problem, and the children that have signs and symptoms apparent at 12 to 18 months are typically the most significantly impaired. I'm trying to turn this timer off. In school-age children, the diagnosis is typically made for higher functioning children. They're usually identified when they have the social problems and the stresses of school, where their social issues and behavioral problems become evident. The DSM is what we use to establish the criteria for mental and behavioral disorders. Autism was not even included until 1980 when infantile autism was introduced in the DSM-3. Don't have this off. The DSM-4 was what increased the concept of a spectrum of disorders with the pervasive developmental disorders. But they later found that the subgroups within PDD were not reproducible across sites and not stable over time. Thus, in the DSM-5, which just came out in 2013, they consolidated all the subgroups of autism into one diagnostic category, and they divided the symptoms of autism into two spectrum areas. The DSM-5 also notes that the diagnosis may be made at an older age when the child is in school or an environment with increased social demands. There was a lot of concern with the change from DSM-4 to DSM-5 about children losing their autism diagnosis, but studies showed that almost all of the children with a DSM-4 autistic disorder or Asperger's disorder met DSM-5 criteria for ASD, and 80% of those with PDD NOS also met criteria for ASD under DSM-5. Social pragmatic communication disorder is a new DSM-5 diagnosis that describes children with impaired social language and not repetitive behaviors. So many of those who kind of lost their ASD diagnosis fell into the social pragmatic communication disorder category. It is noted still that the ICD-10 has DSM-5 4 ASD subtypes and hasn't caught up with the DSM-5. The DSM-5 autism spectrum disorder criteria has 5 different criteria that must be met. There's 2 symptom domains, A and B, which are problems with social communication and social interaction, which is A, and B, restrictive patterns of behaviors, interests, and activities. I'm going to just talk about this a little bit more. So for A, it's persistent deficits in social communication and social interaction across multiple constructs. And you have to have 3 symptoms in this domain. So first is deficits in social emotional reciprocity. That is when you have abnormal social approach, failure normal back and forth conversation, failure to initiate or respond to social interactions. So we might see that they don't have conversations, or their conversations lack that back and forth. It feels more like someone's being spoken to. They may not show appropriate emotions for the situations, may not respond to appear and play. Number 2 is deficits in nonverbal communicative behaviors. We may not see eye contact. They may not orient or identify to other persons in the conversation. There's deficits in understanding and use of nonverbal conversation. There may be even a total lack of facial gestures, or they just may seem awkward. And 3 is deficits in maintaining and developing and understanding relationships. There we see difficulties adjusting their behavior to suit different social constructs, difficulties with sharing imaginary play, kind of sometimes an absence of interest in people. They may say they have friends, but it's not a real reciprocal friendship, may not be able to read social cues, start a conversation. So you have to have 2 of these 3, or you have to have all 3 of these symptoms to meet criteria A. So you have to have all 3. Criteria B is the restricted patterns of behavior, when you have to have at least 2 of the symptoms. There's the stereotype repetitive motor movements, which may be hand flapping, hand wagging, rocking. Kids may line up objects. It may also include some echolalia or idiosyncratic phrases. They have an insistence on sameness. They may have extreme duress, tantrums, even at small changes in their environment or when their routine is not followed precisely. May exhibit difficulties with transition. They have highly fixed and restricted interests, which may show strong attachments to items or perseveration on topics. And new in the DSM-5 is the sensory input criteria, which is hyper or hyporeactivity, or unusual interest in sensory aspects. So they may have unusual or adverse responses to sounds, tastes, textures. They may exhibit smelling or touching of objects. Also would be included as an indifference to pain or temperature. The DSM-5 notes that the diagnosis may be made at an earlier age, when the functional impairment is not really identified until the child has increased demands of social expectations and school environments. And the symptoms have to cause clinically significant impairments in social, occupational, or other important areas of current functioning. This is also part that has relationship to later diagnosis in school. The last criteria is that these disturbances cannot better be explained by an intellectual disability or global developmental delay. These are common comorbid disorders, so you have to identify that these are in addition to their intellectual deficiency, not because of it. Autism spectrum disorder has some specifications that are called course specifiers that were included with DSM-5. So I specify whether or not they have associated intellectual impairment, language impairment, catatonia, a known medical condition, or genetic or environmental etiologic factor. It's of note that Rett syndrome is no longer automatically included as autism in the DSM-5, but it may meet the criteria. Also in DSM-5 are levels of severity, and this was new, and this reflects the impairment of the ASD symptoms and the resulting service needs of the individual. It's not a quantitative score that can be used to monitor progress, and there's really no single score that effectively monitors progress across multiple domains. A number of comorbid conditions occur with autism. Many of them are very important because they can significantly impact the child's and family's functioning. They also can mask some of the symptoms of autism, so they can influence the presentation of the autism or be barriers to screening. And most significantly is comorbid conditions affect a child's prognosis. Some of the comorbid conditions that we see are medical conditions, and I've listed a number of them here, including seizure disorders, which occurs in up to 25% of individuals with ASD. Sleep problems are very common, include bedtime resistance, delayed sleep onset, night wakings. There's other developmental disorders, which are very common. The most frequently seen and associated with ASD is intellectual disability in about 30%. Also 30% are minimally or nonverbal. And then ADHD is another commonly seen in about 30% of kids with ASD. Anxiety and mood disorders, psychiatric conditions, are seen in about 70 to 90% of youth with ASD. And so this is one that you're going to see very often. And then also commonly associated are behavioral disorders. I just don't know why this keeps going. Behavioral disorders. So we see disruptive behavior disorders, feeding disorders, wandering, self-injury, a lot of different behavior disorders. Genetic disorders are also frequently associated with ASD. I don't have the time today to go into this, but has been a lot of technology advancements with genetic diagnosis. And so we know that about 25, I'm just going to take a minute, see if I can turn that on. Whoops, that wasn't it. Well, 25% of individuals with autism are syndromic in nature. So you're going to think about Fragile X, Prader-Willi, Angelman's, Rett syndrome, Down syndrome, neurofibromatosis. They all have those disorders have an increased prevalence of autism, and many individuals with autism have those disorders, but they're not one-to-one. There's also some other kinds of genetic abnormalities, copy number variants, deletions, duplications that are associated with autism. Of the ones that show up when you do testing, many of them are not specific, have not yet been identified. So when you do genetic testing, and we'll talk about that, I think, a little bit later, it's important to recognize that everything you find may not be related to autism. But we do know that it's very heritable. So the risk for twins is much higher. And if you have one child with autism, you're up to 5 to 25% more likely to have another child with autism, depending on the etiology. And actually, I talk about this a little bit more later too. Moving on to screening. So the AAP recommends specific screening for ASD at 18 and 24 months. The general developmental screening that we do at various intervals may not be sensitive enough to the social symptoms associated with autism. Some of the early flags are symptoms of ASD that may alert parents or providers of the risk of autism. I included this table here because this is something that parents will often see. This is in much of the awareness literature that's out there. The CDC has a Learn the Signs, Act Early website. I think part of the reference is on here. And it has a lot of materials to educate parents about developmental and behavioral milestones. Much of this is distributed at daycares and in preschools. So these red flags listed are often the symptoms that parents will alert to. As I said, we recommend the screening at 18 to 24 months. It's important to realize that screening tests are not diagnostic. They just help providers identify so we can refer children at risk for autism for additional evaluation. Rates of autism screening in primary care have increased over recent years with all the additional training that's been put out by AAP and other organizations. In 2015, 3/4 practices in primary care had routine screening. There are some promising screening tests for low-risk infants and toddlers between 12 and 18 months, but typically the screens that we do are at 18 and 24 months because that's where we have the most validated screening tools. The modified checklist for autism in toddlers revised with follow-up, the MCHAT-R, the MCHAT-RF, is the most studied and widely used autism screening tool for toddlers. It's modified for use in primary care for children ages 16 to 30 months. It has a specificity of 0.91 when used in the general low-risk population. In the studies that compared using the MCHAT to just provider levels of concern, the sensitivity of the providers with their subjective assessments was only 0.24 compared to 0.91 when using the MCHAT. When you score it, if they have a score higher than 8, then it's a high risk and you refer. If the scores are between 3 to 7, it's recommended that you repeat the screen in a few weeks. And if it's still greater than 2, so if it's 3 or 7 positive answers, you do the follow-up questions that are online. If you are still fail the MCHAT after taking the follow-up questions, it's a 47% chance of being diagnosed with autism and a 95% chance of being diagnosed with a developmental disability. So this is the pass-fail, and it's really if it's less than 2, you pass. Otherwise, you go through the screen. There's also something called the STAT, which is the screening test for autism in toddlers that's used in primary care for toddlers 24 to 35 months. And this is something that physicians can use in their office, but you have to be trained to do it. There's really no validated screening tools for children over 30 months of age, and that's why it's not recommended by AAP. There is a screening tool, the Social Communication Questionnaire, the SCQ, which is designed to identify some of the risk factors for children ages 4 and older. In the general population, it's pass-fail, but many of those symptoms overlap with other diagnoses such as ADHD. There's a number of barriers to screening that children with milder symptoms or children with above average cognitive abilities often aren't picked up as a toddler. And also certain children with coexisting conditions such as ADHD, those may be the overwhelming symptoms present and may prevent the identification of of autism, ASD. We know that race, ethnicity, and SES do not affect the accuracy of the screening, but because children in lower SES and other minority groups are under-identified, it's probably more related to unmet healthcare needs and lack of screening. The AAP has an autism toolkit, which is a great resource for providers. It has a lot of information about ASD screening, early identification. It also has some billing strategies for screening in primary care. So when a child failed to screen, it's important to know, what do you do next? And when they fail a screen, they need to be get a clinical diagnostic evaluation, and they need to be referred for early intervention or school services. You don't need to wait for a formal diagnosis to refer for the school. Primary care physicians can do some of the clinical diagnosis, especially in the non-complicated cases, if they're comfortable with using the DSM. You can do this in combination with the school system, who can do the cognitive or language testing, and then you can begin intervention. Also, it's important to help families navigate this diagnostic and services processes, because it can be very complicated, and it's important to help families make connections to community resources. Many of the children with autism, however, are going to be more complicated and will need to be referred to a specialist. So when you're doing the evaluation, it's important that you think of this from a multidisciplinary perspective. A comprehensive history and observation of the child are what you use to apply the DSM criteria. The history is obtained through direct observation, through direct interview with parents and caretakers. You can get reports of their behavior from schools or other environments. You can look at the descriptions of the behavior during their testing. That's often included in their reports. And there's some questionnaires you can use to help elicit the history, such as the social communication questionnaire, which I mentioned a few minutes ago, or the social responsiveness scale. And those are sometimes used. I don't know that we particularly find them as helpful. The ADIR is a semi-structured parent interview that you can be trained to use, which also helps with the interview process, particularly in complicated kids. And then observation is the second part of how you get the information for the DSM criteria. And there are some structured observation tools that are validated and that can be used. The ADOS-2 can be used from toddlers to adults, and it's probably the most frequently used observational tool, and it requires intensive training to administer and score. It's important to note that in Nebraska, medical diagnosis and educational verification are generally separate process. A medical diagnosis is given by a medical professional or a team of professionals, and this is really for the purpose of providing medical care, where an educational verification means that the child meets the criteria for special education services. Sometimes the educational criteria are different from the DSM criteria, and so they may not be the same thing. Along with the application of DSM-5 criteria, you need to evaluate cognitive language and adaptive skills as part of the process. School systems are very helpful because they can assess cognitive language and adaptive skills. Cognitive testing uses standardized measures. In kids greater than 3, you get a developmental level, and you get an IQ in older children. There are some validated tests for nonverbal kids. Language testing is typically done by a speech-language pathologist to look at expressive and receptive language levels. There's adaptive functioning, which is typically done by a rating system such as the Vineland or the Adaptive Behavior Assessment System. And often having adaptive function measures which determine the extent that the autism affects daily living are necessary for eligibility for many publicly funded programs. And so this is an important part of it. You do motor assessment, sensory assessment. It's important to look at hearing and vision, and then behavioral and mental health evaluations. When you're thinking about the workup of a child who has now been diagnosed with autism. So after the diagnosis, you want to do a medical workup to look at either coexisting conditions or etiologies. So you need a comprehensive history, including prenatal exposures to medications, alcohol, drugs, prematurity, pregnancy complications, any family history of genetic or medical conditions. The physical exam, look at growth curves, head circumference, dysmorphic features, neurocutaneous findings, and neurologic abnormalities. In terms of a genetic evaluation, the microarray and Fragile X are typically offered in the evaluation of autism. However, you would want to refer for a genetic consultation if they have dysmorphic features or significant intellectual disability, because this increases the likelihood of a genetic abnormality. And geneticists will probably do targeted testing if a specific disorder is suspected. There's a 10% recurrence risk if you have one child with ASD who of uncertain etiology, and a 30% risk if you have 2 children. There's increased risk if you have a known etiology, and that depends on what the genetic syndrome is. But there's also a risk in siblings of having language, other neurodevelopmental, and psychiatric disorders at an increased risk. Neuroimaging is not routinely recommended in the AAP guidelines because abnormal findings are not really specific to autism, and they are no more frequent than abnormal findings in other neurodevelopmental disorders. I included this slide about referrals to genetics just for your information, and it kind of goes over what I just said. Moving on to treatment. The goals of treatment are to minimize the core deficits, that's the social communication and interaction, and the repetitive restrictive behaviors, and any co-occurring associated impairments. You want to maximize their functional independence, and you want to eliminate, minimize, or prevent the problem behaviors that impact functioning. So the goals are not really to cure or to resolve the symptoms of autism, because there is no treatment that does that. So this goal of the intervention is really to minimize the negative functional impairments. It's important to remember that interventions need to be based on objective scientific evidence of effectiveness. And there's more and more data coming out, and on the AAP website, and there's numerous other publications that talk about scientifically validated interventions. So they're going to be based on the age of the child, the severity of the symptoms, and the child's strengths and weaknesses. The IDEA provides assessment and intervention for all children birth to 21. So whatever interventions you're looking at, you're going to be sure to include school in those recommendations. The family needs to be involved in the selection of the intervention approaches and services, and there's many options, such as individual, group, or classroom interventions. They can be implemented by professionals or trained parents. They can be provided by public or non-for-profit agencies or schools or private early intervention services. There's varying intensities and numbers of hours. There is some that involves technical assistance, and some are paid by insurance, which might increase the access to services. So those are all things that you need to think about. Interventions are typically in educational practices, developmental therapies, behavioral interventions, and biomedical treatments. In terms of behavioral therapies, there's a number that are evidence-based for autism spectrum disorder. ABA is when you systematically apply interventions based on learning theory to improve socially important or significant behaviors. ABA can help develop new skills and reduce problem behaviors that interfere with progress. There's many kinds of different ABA interventions, including discrete trial training, verbal behavior, pivotal response training. And ABA therapies are designed and supervised by board-certified behavior analysts. There are some other kinds of behavioral therapies that are more detailed in that AAP article and other articles if you're interested. There's also a number of additional interventions and supports. As I mentioned, educational support is very important. You need to consider the least restrictive environment for kids, which then requires generally an IEP. If children don't qualify for an IEP, they usually will have a 504 plan. And those will target academic and social impairments of autism. It's important to realize that a medical diagnosis of autism doesn't automatically assure eligibility for school-based services. And so parents will often think that since they have the medical diagnosis, they should receive services. So it's important to kind of qualify that for them. And educational support includes a number of classroom models that kind of blend ABA with classroom techniques. Speech language therapy is important. They may use something like the picture exchange communication, or PECS, for a nonverbal child. They may be able to include some augmentative and alternative communication devices. They can focus on the pragmatic language issues. Schools will provide a lot of speech language therapy, but in many cases you need to make a private referral for medical speech language therapy. Also, there's referral and talking to parents about public services through the DHHS and developmental disabilities is important. They need to qualify for that, which will be an evaluation. And it's important to think about this early, because many of the services that a child will want when they're an adolescent have long wait lists. So kids often are put on the wait list in elementary school, and it may be 10 years until they become available. Talking about transition, that's a whole nother lecture. And but there's a lot of information. There's a website called gottransition.org, which has a lot of information about transition planning, referring patients to voc rehab when they're adolescents and young adults. It's important to think about caregiver support and respite services, and also some of the normal activities that families and kids do. So just to remind families that everything doesn't have to be therapeutic. Medical management of associated medical conditions is a huge part of what we as physicians do. And that's because these co-occurring medical and behavioral health conditions have a significant impact on the quality of life. So we're looking at some things like seizures, where there's an increased risk of autism among kids with seizures, and an increased risk of seizures in those with autism. The rate of seizures among people with autism ranges anywhere from 7 to 25%. And in clinical samples, it's sometimes high as 46%. GI is another co-occurring area of symptoms such as abdominal pain, constipation, reflux, feeding problems. And these are more common in children with autism. Up to 75% of kids with autism have problems related to eating, including food selectivity based on texture, color, or temperature, rituals around food presentation, food refusal, and compulsive eating. Pica is another one where you have increased risk for ingestions. The medical management of these is typically behavioral. For most of these GI symptoms, mental health disorders, seizures, you're going to use medication. Sleep disorders, I think we'll talk about that coming up. So in general, you're going to manage a child with autism as you would any child. You want to do all your anticipatory guidance, vaccines, and then you're going to see increased risk, increased presentations of CNS problems, GI problems, and these are typically the same disorders that you're going to have in kids without ASD, although the features of ASD may put them at higher risk. I put this slide up. I hope you can read it. And it talks about medical management of children using medication. And there's been a number of large national studies of insurance claims from big databases, which have shown that the rates of psychopharmacology prescription for patients with autism is about 56 to 65%. So over half of the individuals with autism are on medication, at least at some point. And the use of psychotropic medications increases with increased age, lower cognitive skills, and higher prevalence of challenging behaviors of co-occurring psychiatric diagnoses. No current medication will target the core symptoms and communication symptoms of autism. So it's important when you're thinking about medication, you're not just thinking about what medication do I use in autism, you're thinking about what is the accurate diagnosis of what I'm going to treat. Sometimes you're treating a psychiatric diagnosis in a patient with autism, and sometimes you're treating an associated behavioral problem or symptom. So you may be treating ADHD, a mood disorder, anxiety disorder, or you may be treating aggression, self-injury, sleep problems, hyperactivity that don't fit into a psychiatric diagnosis, but are associated with the autism. So you should really consider medication after you've done a functional behavioral assessment, or you have a good treatment plan in place that includes behavioral health therapy. You need a baseline evaluation with a careful accounting of when the behavior started, what seems to make it worse, and how often it occurs, so that you can monitor progress. And it's really important when you're seeing a change in behavior to do a careful history and physical. You want to look for medical causes such as GI reflex or pain, or otitis media or dental problems may increase head banging. GI reflex might be related to some food refusal. Sometimes kids might have a fracture or a sprain and then demonstrate some atypical motor movements. So you really want to consider medication after treatable medical conditions have been treated and behavior intervention is not successful to address the symptoms of concern. I just made myself a note to mention that integrative, complementary, and alternative therapies are very commonly used in autism. I don't have time to go into that today, but there's a lot of information about natural products, herbs and vitamins, minerals, mind-body practices such as guided imagery, mindfulness, yoga, and other therapies that patients are frequently using. It's always good to ask parents about what kinds of natural or complementary therapies they're using, because they may not bring that up spontaneously. Regards to specific medications for co-occurring conditions, for hyperactivity, impulsivity, inattention, distractibility, those symptoms, or if you have a child that also meets criteria for ADHD, you're going to use the same medications basically as you would in typically developed children. So the stimulants are often a first line choice. It's of note that these may be less effective and have more side effects, particularly in lower functioning or more impaired children. Strattera, atomoxetine is not, and what's important to note that I'm now talking about some drugs that are not FDA approved. for use in ASD, but they're commonly used. So I just wanted to make that statement. So the stimulants are not FDA approved in autism, but are commonly used, as is Strattera, which is not as effective, I think, in autism as in the general population. Alpha-2 adrenergic agonists, clonidine and guanfacine, are frequently used targeting those ADHD-like symptoms. Atypical antipsychotics, particularly risperidone and aripiprazole, there is some evidence of their benefit in these kinds of symptoms, and in Europe and other countries, they may be used more often. But because of the side effect profile, this atypical antipsychotics are generally not used for these ADHD-like symptoms. Repetitive behaviors, irritability and severe kind of disruptive behaviors, agitation, irritability, aggression, are typically treated with the atypical antipsychotics. And the only two that are FDA approved are risperidone and aripiprazole. And these are actually very effective, targeting irritability in kids and adults with ASD. Some of the patients can get by with actually very small doses. So it's important to start these out slowly and advance slowly, and also to monitor for the side effects. Alpha-2 adrenergic agonists are also, there's been some evidence of benefit for the aggression, irritability, and significant disruptive behaviors. There's really not enough evidence to use the anticonvulsant mood stabilizers or the SSRIs in patients with ASD. Sometimes in the most severe cases that we've tried everything else, that might be what is resorted to, but that should not be your first kind of line of thinking. Repetitive behaviors, compulsions, behavioral rigidity, inflexibility are very common impairing symptoms of ASD. There's a number of studies that showed that the atypical antipsychotics have some short-term improvement, particularly risperidone and aripiprazole. The anticonvulsants, there's been some studies that have looked at using divalproex or topiramate with risperidone, but they have a lot of sedative, sedating, and cognitive side effects. The SSRIs, there's really no studies that have consistently shown improvement, but they may reduce the symptoms of anxiety and OCD. So when you see these behaviors pretty severely, SSRIs are sometimes used. Anxiety and depression are up to 5 to 8 times more likely in kids with ASD. As we noted before, the first line of treatment for patients with anxiety and depression is not medication, but medication would be used if they're so serious they impair functioning. The SSRIs have some effect in studies, but there's an increased risk of that hyperactivation or disinhibition. The alpha-2 adrenergic agonists are sometimes used, and they kind of have some improvement with those anxiety-related physiologic symptoms. The same with propranolol, it's sometimes used for that. Buspar, there's been a few studies in older children and adolescents and adults. And the atypical antipsychotics. There's a number of studies that those also have some short-term improvement with anxiety and depression. Sleep, like I mentioned, sleep disorders occur in like 60 to 80% of kids with autism. There's no FDA approved medications for sleep. Behavioral strategies are generally the most effective and should always be tried first. Although melatonin, there's more and more data that's coming out that shows that it may be helpful for sleep onset, and the long-acting melatonin may help with sleep maintenance. When you're using melatonin, it's the dose of 3 to 6 milligrams, and you need to give that sometimes about 2 hours before bedtime so that it has time to become effective. Another thing about melatonin is that if you used it for a while and it's no longer effective, then if you stop it for a few weeks and restart it, you may find that it then becomes effective again. The alpha-2 adrenergic agonists, particularly clonidine, are very frequently used, although the literature doesn't have a lot of support for that. And it's really thought that the use of clonidine is for the sedative side effects and maybe somewhat of the ADHD management. So, and kind of in summary, we always say that the management of autism is a team sport, that you can't do it alone. It takes time. And so you need to know that you can't do everything in one visit, especially if you don't have time for long visits. And sometimes multiple visits are even better because you have time to kind of bring up some ideas and then follow them up, or people think of other symptoms or other questions. So multiple visits. You need to be patient. Getting referrals, accessing clinical care, getting school evaluations and services can be slow and can require a lot of repetitive follow-up or needing to get more information, more intake information. So you need to be patient and help your families to be patient. They hear that, this is the early intervention is important and there's this window, and we know that's true. So you have to be persistent but patient. I think it's important to set expectations and understand the complexity of the case so that you can help parents, patients, and yourself kind of know that this is not going to be straightforward, that it's something you're going to tease apart, and it's not a this is what you have, this is what you do kind of disorder. It's going to be multiple visits, change over time. You need to know your local autism support groups and refer parents of newly diagnosed children, refer those families, because education of families and siblings has shown to be important and improve their outcome as well as improved outcomes for the patient with autism. And then there's you always need to help parents and patients understand that evidence and science should be the source of information for determining treatment, not the marketplace. I think with COVID, this whole discussion of science guiding recommendations, people know what we mean now when we talk about that. Unfortunately, we deal with masks and autism and can they get vaccinations as we do with anti-vaxxers anyway. But I think that this experience with COVID has helped people understand the role of science, and in autism, basing things on science and not the marketplace, not the internet, not what they read in magazines is really important. So that summarizes what I had for you today. I think that AAP article, as well as the CDC website and the AAP toolbox, are great sources of information. Okay, so Laura or Christian, do you take over here?
Yes, thank you so much, Dr. Ellis, for that presentation. We do have a few minutes left for questions, so if anybody has questions, go ahead and type them into the Q&A box and we will be happy to answer, and we have one right now. Will we be able to print off today's PowerPoint slides? So Christina, you should have been emailed those a few minutes before the presentation from Whitney. If you don't have those, go ahead and shoot me an email and I can get those to you.
I believe that those who had registered this morning had sent them, and they did receive a PDF file of the slides. But if there's anyone that didn't, I can actually send them as well
Okay,
to anyone that registered later.
sounds good. I just put my email in the chat. So if anybody else is missing the slides, go ahead and send me an email. I can get those to you. Other questions? With limited time during the primary care appointments, what are the most important questions for a primary care provider to ask a parent or caregiver?
I think it depends on where you are in the process. If you're doing the diagnosis, you want to try to get at those DSM-5 criteria. If the child has been diagnosed and they're coming in for a follow-up, I think the most important question to ask is, how are you doing? And how's your child doing? And show some empathy for their situation and some understanding. And just asking them how they are will often bring up a number of issues that they're dealing with. I think that asking parents how, if what services the kids are receiving, and actually if there's associated goals with that. So how are we measuring progress? How do we know that their child is benefiting from those services? You want to ask them how school's going. There's a number of kind of school reports or rating scales that you can get back from schools, looking at progress. And the schools will actually evaluate progress of kids on the IEP. When you're looking at an IEP and talking about school progress, you also want to know that they're not just targeting the academics, but they're also hitting social skills. And a lot of times the IEP won't really have the social skills unless parents advocate for that. And then I think another important thing to ask parents is if they have support. And there's a number of agencies that will support families. If families are low resource families, there are some places they can get some small grants to buy an iPad. The Autism Action Partnership, Autism Society of Nebraska, Autism Speaks. Those are excellent autism nonprofits and organizations that offer a lot of resources for parents. So to ask them how they're doing, do they have what they need? Are they making progress? Those kinds of open-ended questions are where I would start, and then see where it leads you from there.
Okay, great. And we are at time here, so I'll really